Welcome to the Diabetes Podcast, where we rewrite the story of diabetes. If you're ready to break free from the guilt, the medication, and the fear of complications, you're in the right place. Each episode is packed with real talk, proven strategies, and inspiring wins from people just like you. Yes, remission from type 2 and prediabetes is real, and it starts right now. Let's get into it. Hello, I'm Richie.
And I'm Amber.
And Amber, we got another good day. Today is yet another in a series of good days. And do you know why it's a good day?
You know my answer. It's because every day is a good day.
But specifically this day, why this is a good day.
Let me guess. Because we get to talk about sodium glucose cotransporter 2s.
I don't know. What?
Yeah, we're actually going to be talking about the kidneys.
Specifically, renal glucose reabsorption. And if I can interpret what you just said, SGLT2s, I believe is the class of drugs specifically that are used to treat this. Is that correct?
Yes, because in the kidneys, there are filters that work in the renal tubule and help reabsorb glucose.
Okay.
So
Now,
we're talking about glucose reabsorption.
Glucose reabsorption. So if I understand, we're talking about glucose is in my bloodstream. My kidneys are going to not pull that glucose out of my bloodstream, but dump it back into my bloodstream, therefore keeping my blood sugars higher. Is that correct?
Well, if you don't have type 2 diabetes or prediabetes, it's not a problem. Your kidneys are meant to filter things. Your kidneys are filtering waste. They're filtering sodium salts. They're filtering out sodium and they're reabsorbing potassium. They're reabsorbing the glucose. That's what they're meant to do. So in the normal state, the kidneys are trucking along just fine, doing their job and not creating any harm. But in type 2 diabetes, where you have these elevated sugars in the bloodstream across time, the kidneys will make more of these sodium glucose cotransporters that can pull even more sugar back into the bloodstream, even though the bloodstream is high sugar. The cells are starving and the cells can't take that sugar in, but they're signaling to the kidneys that they're starving. The kidneys are getting the memo, pull more sugar. So they create more of these receptors to pull more sugar back in, which in fact makes the problem worse. Okay. You ever tried to help and made things worse? I know that's never
almost every day.
No, I can't find evidence for that. Well, maybe.
You could look. It's there.
Maybe.
So if I understand, my blood sugar's high, my kidneys want to dump the sugar to bring my blood sugar down, but the cells are telling the kidneys, hey, we're starving for sugar. So the kidneys are operating in a way that they don't normally operate, despite the fact that the kidneys really want to bring that blood sugar down. And probably should, because the cells are telling them that they're starving for sugar, the kidneys are going to dump that sugar right back into the bloodstream. Is that right?
Partially. You got a lot of that right. I'm proud of you. Yes, the kidneys are reabsorbing glucose, and they might not need to. That's the whole point. The kidneys normally would only dump out sugar if the blood sugar in the bloodstream was above 180. But the core defect, Ralph DeFranzo's Dirty Dozen core defects in type 2, is that there's a defect that the kidneys are going to reabsorb that sugar.
Okay.
Remember Ralph DeFranzo?
I don't know who that is.
Yeah, not the Fonz and not Fonzie in the Muppets, but a really pivotal diabetes researcher who identified these 12 core defects with type 2.
I gotta be absolutely crystal clear on this. It's Fozzie in the Muppet.
Fozzie.
I may not know that much about diabetes, but I absolutely know the Muppets.
Well,
okay.
Thank you.
You're welcome.
It's good that one of us does. I know Miss Piggy. So normally, I don't know if I said this earlier, but your kidneys pull out 180 grams of glucose a day back into the bloodstream because it's not effective for your kidneys to spill out good nutrition that you've eaten.
Yeah, we put things in the mouth, and in general, we want to get the value out of the stuff we put in our mouths.
Yes. I mean, some people might think it'd be great if you didn't absorb all that you eat, but honestly, that is what we're designed to do. That's what normal physiology is.
Well, for the majority of human history, right?
Right.
Like retirement wasn't a thing. I was going to spend the majority of my waking hours getting or making or sustaining the mechanisms of putting food on the table.
Absolutely.
Right? All of my thought and effort was into where's the next meal coming from. So yeah, the mechanisms to just dump extra calories was foreign for the vast majority of since humans have been around.
Right. And since the cells are signaling we're starving, the kidney's like, I'm going to help you out. I'm going to create more of these
sugar uptake.
Right? Yeah, we're going to vacuum up some more. They're just not communicating effectively.
Okay.
Signal officer. I think you get that.
Yeah, I understand ineffective communications probably as good as anybody.
We communicate great, though.
Sometimes.
Mostly. Yes. Again, the mechanism within the cell where the problem is, the insulin resistance causes the key to not fit the lock, or there's more fat around the muscle cell, and it just can't absorb that sugar out of the bloodstream like it would in somebody without prediabetes or type 2 or this insulin resistance going on. So there's kind of like a metabolic crisis going on because the bloodstream is overloaded with sugar, the cells are starved for energy, and the kidneys are trying to save it instead of release it, which is where the medicines can come into play. Now, for me, I would say, which is where diet and nutrition and exercise, all of the things that can help reduce insulin resistance through lifestyle change comes into play. But not everyone has established those habits and behaviors. And so medication is recommended to help with this core defect.
Okay. What does the medication do?
We're talking about the class of drugs that's the SGLT2 inhibitors. As you said the other day, Farxiga, Jardiance, and Invokana. Those are three of the more known medications in the class that can help here. And what they do is they inhibit those SGLT2 receptors. So they kind of turn off the vacuum. They are forcing the body to release that excess into the urine.
Okay. It's allowing my kidneys to do what they want to do in the first place, which is to bring the sugar down if it's over 180. Is that right?
Yes. And that does three things. It's lowering the blood sugar. It helps with weight loss because you're literally peeing out those extra calories. And it can, in people who have pre-existing heart conditions and renal disease, it can help be protective to the heart and kidneys in those individuals.
Well, that stuff sounds great. Why would somebody not want to be on these SGLT2 drugs?
Great question. Well, everyone knows that every medication has side effects. And the most common side effects with these medicines, if you think about what we talked about earlier with the core defect being the kidneys are reabsorbing sugar inappropriately, this medicine is dumping sugar and creating sugar in the urine or glucosuria. And that can put a lot of sugar in spaces where you could get a urinary tract infection. The bacteria that could be in your bladder could overgrow. Also, it could be more sugar there to feed yeast and contribute to female genital mycotic infections or just yeast infections.
Okay.
And then more seriously would be Fournier's gangrene. Very rare, very serious.
Can you explain Fournier's gangrene? Because this is new to me. I've heard of gangrene in lower extremities. I think that's pretty common. But this particular brand is new to me. Can you go a little bit into what that is?
Yeah, I mean, the word gangrene is exactly what it is. It is necrotizing fasciitis of the perineum. So, down under spaces.
Okay.
Yeah.
So again, really spelling this out in layman's terms, if I take SGLT2s, there is a low possibility, but not a zero possibility.
Not a zero, very low, but not zero.
That the area between my genitals and my anus could rot off.
Wow. When you put it that way, sir, gives a very graphic detail of this rare
I was
serious
going to use a different word,
side effect.
but again, I felt I was going to kind of keep it professional.
That was professional. Okay. All right. Yeah. So if something is not seeming right and you're on this class of drugs, that is something you want to not ignore and seek attention immediately with. And then last but not least would be the risk of diabetic ketoacidosis.
Okay. I've heard you say that before. I've heard DKA before. And I know that usually involves a trip to the hospital, but I don't really understand what that is. Can you explain DKA for me a little bit?
Yeah. We could do an entire podcast on diabetic ketoacidosis.
And probably will.
So DKA can occur especially in people who are insulin deficient. That's who is at risk the most. But actually, it kills more people who have type 2 because they don't know the warning signs. They are not expecting it. They don't understand that this could even happen. But in the space of, and to be clear, people who have type 2 who do not produce any insulin anymore, it's more at risk for these people. So this is a state where if we talk about going back to the cell that's starving for energy, if it can't get glucose inside the cell, it's going to have to create energy from other sources and utilize fat and protein more for energy. And using this fat for energy, it's going to give off what we call ketone bodies. And these ketone bodies can build up to toxic levels. And one of the ways your body tries to get rid of this is by breathing it off. And DKA can be characterized, or being acidotic or being in ketosis can present with this fruity nail polish remover type breath. And in the setting of the class of SGLT2 drugs, you could present to the ER with blood sugars that are quite normal. I mean, normal for somebody who has diabetes and is more used to higher sugars. Their sugars could be like 200 to 250, but they're still presenting with other symptoms of DKA, which would be like nausea, vomiting, lightheadedness, all of those things. But you go to the ER and somebody less familiar and not asking the question about SGLT2s might think, oh, you've just got a little bug. You've got maybe the flu or something, when it's a much more serious condition. And that is exactly why this is not a class of medications that is recommended for people who have type 1 diabetes. So most type 2 medicines aren't recommended, other than insulin, like oral type 2 medicines, I should say, are not recommended for people who have type 1 because that's just not the core defect of type 1, which is essentially the pancreatic beta cells are attacked by your body's own immune system and you don't have insulin. So you have to inject that insulin externally. But it is a problem with the sugars being high. It'd be good if you could spill excess sugar into the urine. But the problem and the risk of diabetic ketoacidosis is just too great to recommend it for people who have type 1, and it is not FDA approved in that space.
Okay. Would this be a good time to talk about the costs of the SGLT2s?
It would. So one of the costs are the side effects that we just talked about. But another cost would be the copay.
Okay.
So usually that's somewhere between every insurance. I have to disclaimer, every insurance is different and it depends. But typically the copay is anywhere between $30 and $80. So if we took the median copay for that, it costs about $650 a year.
Okay.
Times 10 years, really looking at expense, which is why one of the many, many reasons why we really speak to and want to help people with remission from diabetes. Because if you fix the core defect, if you fix the insulin resistance and the high sugars, then the kidneys will not make more of these SGLT2 receptors to recycle the sugar. So this can be reversed.
Okay. So are there behaviors, are there things that I can do that help the body or help the kidneys specifically in this regard to make the requirement for the drugs less or not at all?
Absolutely. The biggest way to reduce insulin resistance is lose any excess weight if you have it. One of the main things that's a risk factor with type 2 diabetes is age. And that generally is because of the reshaping of the body that can occur with age.
Okay.
And by reshaping, I mean you have, in general, less metabolically active tissue because as people age, they tend to lose lean body mass.
I heard you say metabolically active tissue last time.
I did.
And I really like that, but could you be more specific? What tissue are we talking about? What's going away and what do I need to build up in well, not just in later life, I think all the time, really.
Yeah, all the time. That's great. Metabolically active tissue, when we say that, we mostly, I at least mean muscle and bone density, bone mass. So the more muscle you put on in general, the less insulin resistance is going to occur. And the more bone density you have and the more muscle mass you have, the more energy you're going to be burning just sitting in a chair. Not that we recommend sitting in chairs.
Well, there's a whole nother episode just on that.
We have lots of material.
Lots of material. Yeah, it's good stuff. Just so I'm clear, and full disclosure, I am clear. I just really want to hammer this point home. When I put on muscle, my insulin resistance goes down.
Correct.
Wow. Okay.
Look, I have nothing to add, no rebuttal to that. You did great.
Good.
Yeah.
Okay. All right.
And just to fully answer your question, you asked about different foods that you could eat. Yes, there is oxidative stress that occurs with metabolic syndrome, with insulin resistance, with where your body stores your fat. If you store it more around your visceral organs, it interrupts signaling and it is contributing to this insulin resistance. So if you're eating more fruits and vegetables, especially non-starchy vegetables, you're increasing your antioxidants, you're decreasing that free radical damage that's occurring in your body.
Okay, good stuff. So, and again, this starting to get repetitive, but I think it's going to be.
I think it needs to be.
Move more and get more fruits and vegetables seems to be like kind of the prescription for a lot of this.
Absolutely.
Okay.
Because you can out-eat any diabetes medicine. I've seen it happen I've seen people who are on the max dose of SGLT2s, the max dose of metformin, the max dose they've been able to tolerate and titrate up to the max dose of GLP-1s, are on hefty amounts of insulin, and their blood sugars are still uncontrolled because we have this hole in our face that can take in food. And if the cells are starving, that really overrides your hunger and satiety cues most of the time, because if the cells are starving, your impulse is going to be eat, 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 eat. And it's really challenging. And then if you're able to overcome this impulse to eat, then you almost can, if you don't eat enough, you can potentially slow down your metabolism. And that creates a whole nother set of things that are going on. So the idea is to keep your metabolism, keep your engine running at a very efficient level and fuel it well. It's kind of like an oversimplification, but we can dive into other things later.
Okay. Well, that's a lot, but again,
I think you say that every time.
I do. Like, there used to be this Far Side comic where it has the guy and he's sitting in like the front of the class and he has a very, very small head and he raises his hand and says, "Teacher, may I be excused? My brain is full." And I feel like that regularly. It's for
maybe because his head was so small.
Yeah.
But your head's not really small. We're getting off track. Oh, thank you so much for being with us today. I hope that you have found a little nugget in here that you can take and run with and improve something that you are doing. And I hope it helps you have better conversations with your doctor, formulate better plans on how to move forward. And if you need help with any of that, reach out to us. Yeah. Let us know what your needs are.
Yeah, please use the comment section. We will be very diligent to respond to as many questions as we can. We would love for this to be a dialogue between you and a subject matter expert in diabetes. Ask the questions, get the answers. Additionally, we just are so grateful for this opportunity to get the word out, to increase understanding around this disease that Amber has a lot of experience in, really knows what does not work and what does work as far as taking care of the disease, taking care of yourself, all of that stuff. And next time, we are going to be talking about muscle insulin resistance. And
dun, dun, dun.
Yeah. This one, I say I'm excited about everything. I am really excited about next week's because we are going to be talking about metformin. And
I should have left the dun for that.
It's fine.
It's okay.
Yeah. If you got type 2 diabetes or pre-diabetes, there's a better than average chance you've not only heard of metformin, you're probably on it. And we are going to talk about all of the stuff. So we're going to be talking about that next week. Please tune in, and we will see you next time.
So glad to have you. We'll see you next time. Take care of yourself.
All right. Bye. Thanks for tuning in to the Diabetes Podcast, where diabetes doesn't define your future. If you liked what you heard, please share this episode and leave a review. If you want to hear more, please subscribe to hear the latest episodes. And if you're ready to take the next step towards freedom and energy, head to empowerdiabetes.com to learn how we support real change with real results. Your healthiest chapter starts now. Take courage. You can do this, and we can help.